we're going to introduce our two speakers. So I'm going to, I've got Rebecca, who's just come on. You can see Rebecca now. Hello, welcome, Rebecca. Thank you so very much for coming today. I thought I'd leave it to you to say a little bit about who you are, and we've got two breast speakers today, so we'll do that first and then we'll go into the session properly. So Rebecca's from UCH, but I'll leave it to you to say everything else about yourself. Thank you.
Oh, thanks, Claire. So hello, I'm Rebecca Roylance. I'm a consultant medical oncologist at UCLH, and I also chair the North Central London Breast Cancer Expert Reference Group, which I think is kind of all the right words, not necessarily in the right order, for the new grouping, having the alliance is obviously now split into a North Central alliance. I'll hand over to Massi.
Yes, okay, thank you. Are you there?
Oh, hi, yes, hi.
Hello.
Massi Cariati, hello, thanks for having me. I am a consultant oncoplastic and reconstructive breast surgeon. I work at UCLH where I'm the clinical lead, and well, that's the extent of it, really.
Okay, Massi, thank you so very much for joining us today. So just Catherine, if you could share our first main slide. I think that will come up in a second. Many of you will have seen that before. I can't see it yet, Catherine.
It's coming.
So this is a reminder in terms of who we are as the Cancer Alliance. So as you heard, Rebecca chairs one of the expert reference groups for the Cancer Alliance, and Massi is her colleague. We have 21 Cancer Alliances in the country. They are all work within the NHS, and we're focused on essentially improving the cancer pathway for patients, supporting early diagnosis and treatment, ensuring that we bring innovation into practice, and ensuring that the for us in North Central London STP, that all the hospital providers and the community service that work with us are all on the same page in regarding guidelines, pathways. So we've got a really tailored service for our residents in those 5 boroughs that you can see there on that slide. Next slide, I think, is just a slide that many of you will have seen before, but it's really helpful, I think, just to focus our minds on this for a second. That yellowed area that you can see on this slide, which shows the diagnosed cancer as shortfall between essentially this year and last year and the year pre-COVID. So we're looking for North Central London at over a 900 shortfall in diagnoses, and therefore we've measured that as a 900 plus shortfall in first treatments. So we know that there are lots of our residents walking around town, not realising at the moment that they have cancer, and we need to try to bring those people in so that we can diagnose them and set them off on their treatment pathways. So the focus for all our talks over the last few months has been trying to improve all of our understandings, all of our understanding about the different cancer types. Today it's breast cancer. And I think we'll skip the two. I think there is a slide around housekeeping, but you know the rules properly. So we've all joined us before. So I think we'll leave that just as read. Thanks, Catherine. Can we go to the first slide for the presentation? Thank you very much, everybody. Rebecca, I think it's you. Thanks. I can't hear you. You might be on mute, Rebecca. Thank you. Oh, it's gone mute again. Not quite sure. That's it.
It's very slow. I think, Claire, although I think I'm down first, I think if Massi's happy, it probably makes more sense, because obviously the diagnostic bit of the pathway first.
Absolutely. Massi, are you happy to take over? Thank you.
Yeah, I am. Should I share my slides?
I think that's please, fine. Yes. Thank you, Massi. Yeah.
Yeah. Okay. Just bear with me for 1 second. And I'll do it. let's see. Oh, sorry, I'll get rid of that. Just one moment.
No problem.
Yeah. That's it. So can you see the title slide?
We can, Massi, thank you. Yeah.
Great. So, well, thank you very much for having me. This is going to be just a brief session on the diagnostic aspects and some surgically relevant treatment aspects with regards to breast cancer, and particularly the impact that COVID-19 has had and the experience we've had over the last 12 months or so, and where we could go from there. So I'll talk about a little bit of breast cancer facts and figures, and just briefly touch upon pre-COVID NICE guidelines for referral, and explain a little bit the impact that the time of presentation has on successful treatment, and then move on to explain the impact of COVID-19, our response, and adjust the guidelines, and then, you know, opportunities for recovery and what the challenges are. So, as I'm sure many of you know, breast cancer is the most common cancer in women in the UK, and it is the second biggest cause of death from cancer in the female population. About 1 in 8 women in their lifetime will be diagnosed with breast cancer, and that amounts to about 55,000 new diagnoses a year. The remarkable change that we've witnessed since the 70s and early 80s, where survival rates were only around 50%, it's been mostly thanks to improved treatment, but particularly earlier diagnosis. And so nowadays we see that we've got about an 85% overall survival at 5 years. So, as you may know, breast cancer has sort of a bimodal diagnosis peak in terms of age at diagnosis, and so the majority of breast cancer patients are diagnosed around the age of 50 to 55, and then later in life around the age of 70 to 74. And there is a relatively smooth rise and descent in the likelihood of diagnosis of breast cancer with age. And as you can see, patients below the age of 40 are very rarely diagnosed with breast cancer unless they have an underlying genetic abnormality. It's quite unusual to have sporadic cancers below the age of 40, and that's relevant with regards to referral. Now, this may look a little bit small on the screen, but in essence, the route to diagnosis...
Massi, the slides are not moving.
They are not moving?
No. Oh. You need to click play on slideshow. You're still on the first slide.
I'm still, okay. Sorry about that.
Okay.
That's fine now. We've got the route to diagnosis slide. Thanks, Massi.
Yeah. So yes, so with regards to route to diagnosis, well, traditionally, patients present either through screening, which is the first bar, and about 25 to 30% of patients are diagnosed via the screening route, and then via GP referral, either through the 2-week way referral pathways or as a referral directly from GP, but outside of the 2-week wait. And that amounts to about 70% of cancer diagnosis. And then other modalities through other outpatient departments or inpatient referrals or emergency presentations actually amount to a very small number of new cancers in breast. Now, with regards to the route diagnosis is directly correlated to the stage at the time of presentation. And so, as you can see, where the light blue is stage 1 and darker blue is stage 2, and so on, 3 and 4, or stage unknown, that patients who present through the screen detector route have a much greater chance of presenting at an early stage, as it seems logical. And equally, patients who present through the 2-week way or a GP referral have a reasonably good chance to present within stage 1 or 2, and only a small minority of patients will present with stage 3 and above. Now, the reason why this is relevant is that when we look at 5-year survival by the stage of diagnosis, patients who identified in stage 1 have a near 100% survival rate at 5 years. And patients identified in stage 2 had a near 90% survival at 5 years. However, when we moved into stage 3, there is a drastic drop in the percentage of patients who are alive and cancer-free 5 years down the line. And so the late diagnosis has a significant impact on successful treatment. And no matter how advanced our treatment options are nowadays, and Rebecca, I'm sure, will tell us a lot about the latest options for treatment, the late diagnosis is probably the biggest factor in influencing poor survival. Now, traditionally, the NICE guidelines updated in 2015 and then later for breast, essentially for two-way pathways, look at referring patients either using a suspected cancer pathway referral for patients who are age 30 and over with an unexplained lump in the breast or in the armpit, with age 50 and over with changes to unilateral nipple, such as discharge, retraction, and then to consider referring patients on a suspected cancer pathway referral for skin changes, particularly unilateral skin changes, and then, as I said, age 30 and above with an unexplained lump in the axilla. Now, the reason why those symptoms are the ones that recommend a referral of patients through a two-way suspected cancer referral pathway is because when we go and look at the frequency of cancer diagnosis in patients who present with either of these symptoms, we see that patients who present with a breast lump represent approximately 3/4 of the patients diagnosed with symptomatic breast cancer. And actually, known lump breast symptoms only constitute approximately 11% of the overall patient population when in isolation. The overlap of breast lump and other symptoms of the breast amounts to about 6%. And then patients who present with non-breast symptoms, such as axillary lumps, neck lumps, lymphedema, for instance, or systemic symptoms only represent a minority at 5%. Now, so that sort of makes us understand a little bit that, if we think about the age at diagnosis, the likelihood of breast symptoms being associated with cancer, and then what symptoms are most likely to actually be associated with a cancer diagnosis. Obviously, a woman in her 50s with a lump is truly an urgent referral. A woman in her 20s with breast pain, perhaps, does not need as urgent a review. And this is particularly poignant in the context of the current reality where capacity and opportunity for review in person might be affected by existing infection prevention control measures. And so to try and optimize the utilization of those lots. Now, COVID, the first case was confirmed in the UK on the 30th of January of last year, and it has had globally a significant impact on healthcare in general, but also on cancer care. So, as I'm sure you remember, on the 17th of March, essentially NHS England said that all non-essential operations needed to be postponed, and this was primarily aimed at freeing up a large bed capacity to accommodate possible intake of COVID patients. And so that led to a requirement for rationalization of resources and to establish some prioritization of delivery of care in case we found ourselves in a scenario where resources were not sufficient to match the number of patients who presented. So new guidelines were developed, updated with considerations with regards to COVID, and this was done both at national but also local level. And in fact, in North Central London, Tumour Working Group was amongst the first sort of multidisciplinary collaboratives to issue guidelines which were then implemented in daily practice. Communication was released, which explained effectively that all patients were going to be triaged. And I'm sorry, this on the small screen is going to look tiny, but all patients are going to be triaged telephonically to ensure that infection prevention control measures were going to be taken into account before bringing the patient to clinic, and that certain patients, then the patients would be prioritized on the grounds of the type of symptoms and the circumstances. So this is not going to show very well. Let me try and see if I can make it a little bit larger. But in essence, guidelines were released and then updated through and through on a bi-weekly basis, on a twice-weekly basis over the course of the first wave of the pandemic. And these guidelines took into account the impact that COVID would have had on services, and so addressed the opportunity for reviewing patients in outpatient services, and again, triaging questions to avoid bringing patients with possible COVID symptoms or might have had a possible COVID contact to clinic. And then guidelines with regards to who would have had a 2-week wait appointment. And so all patients aged 30 and above with breast or axillary lumps or suspicious nipple discharge or skin changes suspicious for cancer. In essence, all the patients that truly belonged to the risk categories were going to receive a 2-week wait appointment. But the ones with lower risk symptoms, such as younger women or isolated breast pain, or possibly males below the age of 50, were only going to receive a virtual consultation first, and then a face-to-face appointment would be arranged if required. This eventually was reflected in the Pan-London revised 2-week wait referral form, which you're all familiar with, I'm sure, and again identified those high-risk symptoms in patients aged 30 and above, and then breast symptoms in which breast cancer is not suspected, young women with a lump, persistent asymmetrical textural changes suspicious of infection, or eczematous skin changes. And there was some guidance added to the form on how to manage patients who presented with isolated breast pain, and equally how to manage men presenting with isolated gynecomastia. This was all done in the interest of making sure that the reduced capacity of appointments would actually be dedicated for patients who are more at risk of a cancer diagnosis. Now, I said the changes and the guidelines introduced impacted not only pathways for referral, but also treatment options. And so from a surgical perspective, we revisited our current practice to try and avoid exposure to COVID for our patients and to try and facilitate safe treatment. Now, this was primarily driven by early publications out of China, which demonstrated that patients who were treated for elective surgery without an idea as to whether they might be carriers of COVID or not had a high incidence of activation of COVID postoperatively, and with mortality rates as high as 20% in the elective setting of patients who were deemed asymptomatic before treatment. And so that drove here nationally in the UK a desire to ensure that we would be able to provide as safe a treatment pathway as possible to our patients. So patients were required to isolate for 2 weeks prior to surgery, were screened with COVID screens 72 hours in advance of surgery, and then were operated on, provided they were found to be negative for COVID, in dedicated facilities, which are now deemed, which later were called green pathway or green treatment pathways. Now, these were established within the independent sector here in central London, and allowed actually the treatment of the majority of the patients who presented to our attention during the period of the pandemic, with only a minority having the treatment protocols truly changed because of COVID. In order to prioritize patients in the grounds of ensuring they would deliver treatment, particularly surgical treatment, to the more urgent patients, we established some priority levels, priority level 2 and priority level 3. Priority level 2 meaning surgery to be delivered within 30 days of intent to treat, and priority level 3 instead, where patients would be deemed suitable to potentially wait longer, as alternative strategies existed to hold off the patient for the intermediate time and or such as in the case of low and intermediate grade DCS, the level of risk related to the cancer diagnosis was low. And so, as you can imagine, surgery for local control, triple negative breast cancer, post-neoadjuvant treatment patients, those were all prioritized. Young women with ER-positive disease and node-positive disease, all prioritized for treatment, whereas smaller cancers amenable to preoperative endocrine treatment with letrozole, for instance, or DCIS, or benign conditions were all deferred to a later date. The issue of immediate breast reconstruction is a particularly poignant one because this was suspended at national level from sort of late March, and therefore a number of patients found themselves requiring a mastectomy and not having the opportunity to be offered immediate breast reconstruction. And so there is a cohort of patients in North Central London who will have undergone a simple mastectomy who might have been suitable for an immediate breast reconstruction and who are currently awaiting delayed reconstruction as part of this impact. So with regards to that, the ongoing challenges are to a degree some that we've already mentioned. One of the lost symptomatic patients, as Catherine was saying at the very beginning, there is a significant gap in intention to treat patients, of first treatment patients, between the last 12 months and the year prior to this or the previous years. And that suggests that a proportion of these patients at least will probably be in the community, having experienced breast symptoms, not having sought review, and therefore not having been assessed. And some of these will be cancer cases that will present later at a later stage, and for whom therefore prognosis will be worse. There is an element of challenge relating to screening recovery, and that is related to the fact that the national screening program was suspended between the end of March and the end of June, and so for 3 months none of the screening investigations were sent out. That capacity has gradually recovered, and it's now picked up to about 6,000 screening invitations a week. There remain, however, a large volume of patients who nationally will not have received an invitation and for whom we're playing catch up essentially. And so there is an effort that is undergoing to try and increase the screening capacity in an effort to bridge this gap. As I said, and I'll show in a moment, but there remains a challenge with regards to capacity in breast units for symptomatic assessment. And this challenge is largely related to infection prevention and control measures, which, despite the fact that COVID has become less prevalent within the community, remain in place, and rightly so. And so whilst the number of referrals on a weekly and monthly basis has gone back up to numbers comparable to the ones in the pre-COVID era, the capacity to see these patients has increased, but has not increased going to the levels that existed prior to COVID, and therefore we are struggling to meeting targets, and we're struggling to see these patients by day 14. As I mentioned earlier, a number of patients were established on preoperative antihormonal treatment in an effort to bridge the gap between the time of diagnosis and when time for treatment might have been possible. And so there is not so much in North Central London, where we've been able to offer surgery to the majority of our new cancer patients over the last 12 months. But in other areas of the country, there is a backlog of patients who've been established on endocrine treatment and are awaiting surgery as a result of this change. Repatriation to the home trust, and particularly in our case, UCLH, has happened. We're back on site from operating off-site in independent sector facilities, but that repatriation is somewhat slow due to the volume of cases, particularly non-cancer work that have built up over the last 12 months. And so patients who require surgery in day surgery regime routinely have no issues at the moment, but anyone requiring an inpatient stay risks getting cancelled due to an ongoing shortage in beds. We've touched upon the backlog of delayed reconstruction cases already. So these figures here are similar to the ones that Catherine was showing, but in essence, you can see how the number of referrals within North Central London in April and May of last year, and also June, was significantly lower in 2020, 2021 than in preceding 2 years. But that number of referrals has now caught up, and it's actually in line with what we've witnessed before. And so the gap that we've talked about primarily sits in this section. Another slide also through the Cancer Alliance, where in essence showing that this is the first seen performance, and to just drive home the point of a challenge in the gap between number of referrals and existing capacity. And you can see towards the last few months when the number of referrals has increased, but capacity was continuing to be affected by the second wave of the pandemic. The number of patients seen within 14 days, which is the green bar, is below our targets. And the same goes for first treatment within NCL. In 2020, 2021, first treatments for the first half of the year last year were well below the figures, the comparable figures from the preceding 2 years, and then caught up over the course of the autumn, and then dropped back down over the course of the winter because of the second wave and the transition to the independent sector once more. So in conclusion, we talked about the challenges, and I think these challenges also, however, offer opportunities, and these opportunities are primarily related to revisiting how we offer our one-stop services and our symptomatic breast services in an effort to try and optimize the patients we see and offer appointments to the most urgent patients and to the ones who need to be seen most, whilst also continuing to assess the ones who have less worrying presentations. And so this could be achieved through the establishment and strengthening of an advice and guidance approach, which is ongoing and certainly provides the opportunity to seek advice from breast services, from primary care, without the need to necessarily refer the patient in, depending on what the nature of the query is, by performing clinical triaging to try and distribute and sort of allocate patients to the most appropriate type of appointment, avoiding poor utilization of the one-stop clinic appointments, which has in the past been certainly a sticking point, revising guidelines in an effort to try and once again optimize the referral pathways as well as the treatment pathways and the treatment protocols, and then implementing, as it is in line with certainly push from NHS England, a high volume of virtual clinics. We have certainly started doing so at UCLH, where in an effort to reduce footfall within our cancer centre, we are primarily carrying out wound clinics virtually 1 week post-operatively with clear instructions and run by a nurse, and then the patient is brought in if there is a need or a concern. By implementing stratified open access follow-up, once again providing an opportunity to reduce the number of patients who are scheduled to come into our clinics, but who could be actually managed telephonically following end of treatment appointments where the criteria for seeking a review are explained clearly. And then, and finally, another opportunity that we certainly had is the coming together of the various units and the multidisciplinary working groups that were established over the course of the pandemic has certainly provided a great forum for discussion and for standardization of certainly surgical work across the whole of North Central London. And that's it.
Massi, that's great. Thank you very much. It's Claire here. Marina's said she's just going to have to leave. I don't know whether you're still around, Marina, to ask your question, or otherwise I'll ask it for you and then we'll post the answer back. Yeah. Okay. So Marina was the first person to shout out if you're still here. Right. Okay, she hasn't got a microphone, so I'm going to speak for her. So Marina asked a question, Massi, which was that she's got a male patient with a few years of gynecomastia. Who's been reporting pain affecting him daily, and he is keen on intervention. What do you think in this situation is the most appropriate, suitable clinic for her to refer to apart from the 2-week wait? Because she couldn't find anything else available on ERS when she was checking ERS.
Sorry, Catherine. I think I fell off my
Okay.
connection.
Question.
I only just rejoined.
Okay, sorry. So I was sorry, it's Claire, not Catherine now speaking, Massi. So Marina asked a question. She's one of our GPs, saying she's got a male patient with a few years of gynecomastia, reporting pain affecting him daily, and he was keen on intervention, pushing for referral. Marina hasn't got a microphone, so she can't speak, but she can put stuff in the chat. So I'm presuming on examination there was nothing to find. What was in this situation, the most suitable clinic that she could refer to apart from the 2-week wait clinic, because she can't find any other clinic options on ERS?
So, the patients with gynecomastia are always a bit of a challenge. The main reason being that, as you may be aware, the CCG's guidelines with regard to procedures of limited clinical effectiveness has changed and has become tighter over the last couple of years. And so the majority of patients with gynecomastia are unfortunately ineligible for surgery. Funding is frequently refused or declined. And so if the main reason why the patient is seeking review is related to the desire to undergo surgery, then that can be approached in the first place through the advice and guidance sort of requests. And then if the patient is persistent and requires review, then perhaps it could be brought directly to a consultant-led clinic. So if the referral was to come through a 2-way wait pathway, would then be triaged into the appropriate clinic, because at the end of the day, if the patient has established gynecomastia and we don't have particular concerns and the patient is younger than 50, and so it's unlikely to require imaging, then the one-stop appointment is probably not the best one for that patient, and instead coming to see a consultant to discuss why, to make sure that it is gynecomastia, but then why, unfortunately, the opportunity to have surgery for it is not really available outside of exceptional circumstances. Okay,
so often reassurance is really helpful in this situation. So in terms of arranging the appointment, we would have to use a 2-week wait referral, but mark it as non-cancer. I think Marina, all of you will see on the 2-week wait forms, there was that option. Rebecca, do you want to come in here? Is there anything you want to add here around referring for at least some specialist advice for a patient in this situation?
Yeah, thanks, Claire. And in fact, I'd put something in my slides about, and as you know, the sort of referral in for metastatic disease is often very difficult. And I've long asked if we could just have a referral route directly in. And I know that's often difficult for you in terms of your referral pathways. But I think hopefully with COVID and how things have been changing, we'll get a bit more flexibility, because clearly someone who's got symptoms and signs suggestive of metastatic disease shouldn't go via the 2-week wait. And while, if trusts have got their pathways sorted out, they can be diverted. So often these women end up in a 2-week wait clinic, they get breast imaging, and of course that's all normal. And, by the time they get their scans, you're just delaying their diagnosis of metastatic disease.
Yeah. And what about the particular case of this man that Marina was talking about in his 20s with early gynecomastia? Would you, if it's only plastics that he's after, then clearly, as Massi has said, he's unlikely to be successful through the Polkey approach. But from our perspective in general practice, being able to hear that once from a specialist is really valuable for patients. So rather than being, they'll often not be satisfied by the dialogue in general practice. So how would you think the best thing would be advice and guidance and then ticking the box to allow an upgrade to an appointment if the clinician felt that was appropriate, or should we be looking at a different separate path in, which might be something, as you said, that we could consider now?
Yeah, I mean, I guess ideally a separate path in, just so it's,
yeah,
we're stuck, aren't we, with this? Any breast symptom needs to be seen within 2 weeks, when
yes,
as you and I have discussed a lot, that's not necessarily necessary for all. And that's what I think, you know, Massi was highlighting with the whole telephone triage, not saying to slow things down, but so just to make sure patients get seen more appropriately and triaged inappropriately.
Yeah. And in fact, someone else has put something else in the chat. Sinapu has said that she has already tried Polki, but for a patient, and it's been unsuccessful because they don't have what's described as grade 3 gynecomastia, and it's caused significant effect on their mental state. So we'll take this away actually, and perhaps both of you, and we can have we'll have another discussion at the Alliance about how we might be able to move forward in the new world around these sorts of referrals. Okay, thank you. Thanks
I think that would be
very much.
great. And particularly, of course, you know, in the current scheme of things with the pandemic and capacity issues, unfortunately, gynecomastia won't be sort of, you know, that particular referral you're talking about. It might have been handled differently had there not been so much capacity issues at present.
Yes, now I understand. Yeah, absolutely.
Yeah, and just briefly to add, I mean, the same applies to patients who are seeking a bilateral breast reduction, and some of whom have a very valid, you know, point, you know, truly affected in their daily life by the size, shape of the breast, by the weight. And it's really quite challenging to actually be able to demonstrate that all the criteria have been satisfied in an effort to sort of then secure funding. And I see how, you know, from a primary care perspective, you know, some of these patients will be quite distressed about the symptoms and about the impact that, you know, their breast is having on their quality of life. And so perhaps, you know, the route in if the consultation in general practice is not sufficient, the route into advice and guidance, and then to be directed into, you know, the appropriate consultant-led clinic to be able to have a more comprehensive discussion with a clinician. If they go into the one-stop clinic, they're only going to have a limited amount of time dedicated to them. They may get a scan which they don't need, but they're not actually going to have their queries and concerns listened to appropriately and then answered adequately. And that's why the opportunity to have different pathways into the system for review, depending on what the symptoms, what the reason for referral is, it's really important.
Yeah. Okay, well we'll take that away and have a discussion about it. We moved to for those of you who were practicing after we moved to a single pathway, and that in fact also appeared initially to be for very good reason, and Rebecca will probably remember this. I mean, it's 15, 20 years ago, is it now? 15 at least. And came from the fact that some people got into the wrong pathway, some women got into the wrong pathway, and those pathways were not time measured, and therefore they waited some people were in fact incorrectly in the wrong pathway and had breast cancer and waited too long, and so nationally a decision was made to take the other option. But it's worth considering again for certain conditions, I think. And well, again, Sinapu's popped in the chat how difficult it is to manage from a GP perspective when and I take that on board. It is difficult, but in fact we do have a Polki system across the whole North Central London. So let's have a look at another question. Michelle, do you want to speak your question? Michelle from Wentworth.
Oh, hello. Yes, sorry.
Hello.
It might seem a simple question, but when I do my cervical smearing, I always then go through with the ladies how to check their breasts. And on quite a few occasions, I've had women that have had silicone implants. So I do the normal about you raise your arm up, you look in the mirror and you check your nipples. Is there any, and you, et cetera, what we've been told to do and everything. But is there anything else? because it is difficult if they've got silicone implants. I mean, it might seem silly, but it is difficult for them to feel a lump. So obviously we know about, is there any discharge from your nipples? Is there, because they can't really see, will they still be able to see changes in their breast tissue above the silicone?
Thanks for the question. So yeah, no, absolutely. So I would say that generally speaking, the implants do make things trickier because they make it more likely that, you know, they may identify changes that are not so much related to the breast, but are more related to the implant itself. With regards to feeling lumps in the breast, generally speaking, if a patient has an implant in place, because of where the implant sits, which is either right underneath the breast tissue or underneath the pectoralis major muscle, it shouldn't affect their ability to identify a new lump. But of course, what they may be feeling is a ripple in an implant, particularly at the edge of the breast, and so they're more likely to end up being seen in the one-stop clinic as a result of that. The two very important things and messages to be driven home with regards to these are the possibility of lumps in the armpit, which can happen as a result of silicone migrating from the breast into the lymphatic channels and then into the lymph nodes in the axilla, and that will manifest with enlarged nodes. And so if they do identify those, well, they need to be seen just to make sure that there isn't a more sinister reason for it. And then the possibility of what's called anaplastic large cell lymphoma, which is a sort of lymphoma, the scar tissue around the implant, which has now been identified as sort of 1 in 20,000 implants in the UK, but globally about 1 in 5,000. And that's something that, if identified early, is completely curable. But if identified late, it can be a disease with very poor prognosis. And so the way these patients would probably notice is a sudden and relatively rapid swelling of one of the breasts years after having undergone either an implant-based breast reconstruction or a breast augmentation with silicone implants. So these patients should know that if they have swelling of the breast that is unjustified with no recent history of trauma, that they should be seen, because that could be related to something potentially significant.
Thank you.
Thank you.
Thank you very much.
Right. I think, thanks. That's a great discussion. I'd like to move on now to Rebecca, because we're pushing the clock a little bit. So Rebecca, can we invite you to give your presentation, please? Thanks very much.
You can. And can I just check, are we finishing at 1:30?
We have to finish at 1:30. In terms of, most people have planned for that kind of time frame. I mean, I'm always happy to ask if people want to continue afterwards, but I think there will be some people that would need to leave. But from my perspective, I could do that, and it sounds as if you might be able to do that. But should we take a view, or do you want to take a view at the end?
Yeah, no, it's just whether to sort of whiz through.
Yes, yeah. We'll have to. You might have to have it. I mean, the other way of handling is that you do a part of it, and then we reschedule part 2, because I think lots of questions. That's another way of doing it.
Well, because I was going to talk a little about COVID and the impact that's had on systemic therapy, and then give a little bit of an update of what's relevant in terms of breast cancer management for, obviously, you all in primary care. So perhaps we'll do the COVID and then
reschedule the rest. Yeah, that's fine. Yeah, we could do that in quite a short time frame, I think.
Okay.
Yeah, that's fine.
Now let me wrestle with the technology, because you might not be able to. I don't know where my slides have disappeared to. I thought they were sharing.
Someone's got their desktop up. Is that your desktop? Yeah. I can see April presentation for GPs May 21 halfway down. That's it.
No,
Rebecca, if you want me to share it, I've got it open.
Thank you. Is that okay, Rebecca, if Fanta shares it?
If you, yes, although I won't be able to, I'll have to then do next slide. So let me just 2 ticks, or maybe longer. I don't know where it's gone. I tried to be efficient and get it ready while Massi was talking. Fanta, I think you're going to have to help. Oh, hang on, no, I think. No, Fanta, I think if you don't mind sharing, it seems to have disappeared, unfortunately.
Can you see that?
Yeah, we've got that first slide. Yeah, lovely. Thank you very much.
And if you can just move to the second slide then, Fanta. Okay, so, well, let's move on, because that's what I was going to just talk you through. I mean, Massi's talked to you about the early diagnostic part of the pathway and how we've adapted during COVID. I think it's really important to say that on the whole, we have been able to manage oncology services throughout the pandemic. And that's really, we've done that via altering our usual pathways and adapting. Consultations now are mainly remote, and they continue to be remote. We see patients that we need to see, but obviously particularly at UCLH, where we are a standalone cancer centre and have a large haematological population, all of whom probably have not such good responses to the vaccine. Even with all the introduction of the vaccines, we still need to be very cautious about footfall within the cancer centre. And also, as Massi talked about, particularly during that first wave, we didn't really know how patients were going to cope with the infection, how sick our patients would be. And certainly during that first wave, we had prioritization. So just as with the prioritization of surgery, we prioritized systemic therapy. And by that, we of course maintained treatment for all those high-risk women that really needed treatment, so the triple negatives, the HER2 positives, those in whom treatment with systemic therapy is curative. But where possible, and particularly in the metastatic setting, if we could switch to oral therapies which were less immunosuppressive and obviously avoided the need for patients to attend the day ward, we did. So there was increased uptake of oral therapies. And in the prioritisation for those women in whom chemotherapy was being offered but had a very minimal impact in terms of increasing length of time of women on treatment, and it wouldn't add much to their lifespans, then those women were the ones where we felt probably the risk of palliative chemotherapy outweighed any benefits. But subsequently, as we have learnt how to manage patients on chemotherapy during the COVID pandemic, understanding how actually outcomes weren't particularly worse, looking at how we could really keep women safe. And we have managed the subsequent much bigger wave much better with minimal disruption. We've still continued the alteration in the pathways, but on the whole, we have not stopped treatments. And I think it's also important to say that throughout the sort of supportive treatments and things that we could easily defer, we did so. So, for example, we had about a 3-month deferral of all the adjuvant bisphosphonate therapy. What was very helpful was that a trial was published just around the time of the start of the pandemic, which confirmed that decreasing the radiotherapy fractionation from the usual 3-week schedule to just a week, so just 5 days, was not inferior in terms of outcomes for local control. And so that was a really timely clinical trial result, because it meant that all the clinical oncologists, and I have to say I'm not one, but they were able to reduce the frequency of fractionation, and that was a really rapid introduction into standard of care, and was hugely beneficial because, of course, around the country, both breast and prostate took up the majority of the radiotherapy fractions, and so to be able to decrease not only footfall through the radiotherapy departments, but give a treatment that was as efficacious made a big difference in terms of capacity during particularly the first wave of the pandemic. Fanta, could you move my slide on? And so I think perhaps just worth saying here, and then I will stop, that the introduction of novel therapies or novel ways of working, increasing use of oral therapies, getting those drugs delivered via courier and so on. So again, so women didn't need to attend the hospital, were all hugely beneficial during the pandemic. But now during the recovery, I think we will need to continue with these different ways of working in order to sort of keep up with demand. And certainly I think going forward, there is a projected significant increase in systemic therapy capacity needed, largely because of other cancer types where diagnosis has been delayed. And of course, if you're presenting later, the chances are that people will need more systemic therapy. And so I think going forwards, we will need to continue to look at our pathways, look at the more novel routes of therapies and routes of delivery. And one of the things is, of course, increased self-administration of drugs like dinosaurmab. Claire, you'll remember very well our project to get that into the community, get that sorted out. But I think given the time, I'm conscious that probably most people have only got about 5 more minutes. But maybe if you want to take questions now, I'm happy to stop and, as I said, go back to updates at a later date.
Right. Okay. I think, I mean, I'm just looking at in terms of questions at the moment. I think we're all right. I haven't had anything new posted, so probably I mean, you could continue a bit. You might want to explain what dinosaurmab is for people who are not sure, just a quick summary. And then I think one of the things that is difficult for general practice is if patients come back and say, well, they've changed this, they've done that, what do you think? Of course, we often haven't got a specialist view on the change of systemic therapy, but it is one does want to try to respond to the patient in one way or another. So I don't know whether you think advice and guidance is the best, or whether we should just be re-referring that person straight back to their CNS to try to take that dialogue forward.
Yeah, thanks, Claire. I mean, I think it's probably a bit of both. I think one would hope that we have explained it well, and of course, it's always the case, isn't it, or often the case, that patients don't necessarily take in all that you've said at that consultation. So I think it's very much dependent on what sort of queries they're coming up with. If it's a need to rediscuss the treatment, is it as efficacious, what changes have been made and why, then that's probably something that we should see them about to rediscuss. If it's sort of other queries, then certainly the CNSs can answer those questions, and all the patients should have their contact details for the CNSs. Yeah.
Yes. Thank you. Here's a question. Let's have a look. Do you want to, can't see who's popped that question in the post. Do you want to speak that question yourself? Someone's just posted something which I've flashed up and then disappeared.
Yes.
Did you see it? Did anyone else see it?
I didn't see a full, no, okay. I saw it flash up and then...
I was, okay. Yeah, so that perhaps that fine. Okay, so
sorry, Claire. Sorry, was that the question about advice on female patients who've had breast implants? Is it that question?
No.
Oh.
No. Okay. Someone, Dr. Ganielli, has said, I'd like the slides if possible. So perhaps that's what. So yes, we do share the slides, don't we, Catherine? Do you want to just explain where they are for a second?
Yes, we can share the slides, but the whole webinar will also be on YouTube in a couple of days, so you'll be able to look at the whole thing again there. I'll post the URL for the YouTube channel.
Thank you. Thanks very much. Okay. So why in the last 4 minutes, Rebecca, do you want to say anything else, particularly? Just and I think, as I said in the chat, we will definitely organise something as soon as we possibly can to have a sort of follow-up breast webinar, because there's lots of different areas of breast disease that people are really keen to explore. We might do a bit on male breast cancer as well, perhaps. Can I just take you back to the dinosaurmab question? So not everybody may be aware why people get dinosaurmab and how it's now possible to have it in terms of the treatment regimes.
Sure. So dinosaurmab is a specific drug that we give for the management of bony metastatic disease. It helps to reduce pain at the bony metastatic sites, and also helps to keep the bone strong, so reduce the risk of fractures and so on. It's given 4 weekly subcutaneously, and we have introduced this patient self-administration, which of course saves patients having to attend the hospital. It's much more convenient for them because of course the subcut injection is very speedy, but they would often spend hours sitting around, waiting around for their injection. So it's been very well received.
Yeah.
I did have a few slides on it.
So we can perhaps go over that.
Yeah,
next
we can
slide.
talk about that another time.
Yeah. It's certainly
and
something.
I think, yeah.
Sorry.
No, I was going to say, Claire, I think it's useful to know as well the things that you'd like to hear about in primary care. Certainly, I was planning to give you an update on adjuvant endocrine therapy, because I think that's something that's evolved over time, and it's something obviously you all prescribe and often need advice on.
Yeah, absolutely.
Adjuvant bisphosphonates are something that are new really in the last couple of years, and again something that you often help us prescribe. And then obviously some updates on what's going on in the metastatic setting, just drugs that you will see us writing about a lot and not necessarily know how to manage some.
Yeah, no, absolutely. Absolutely. Yes. No, thank you. That's great. So I really just want to say thank you to both of you. And it's a huge, breast disease is a huge subject. And of course breast cancer affects so many women, one of our commonest cancers in the UK. And so it's only right actually that we find some more time to explore it properly, which we will do. Just in the closing minute, I'd like to say to all the GPs and nurses, GP practice nurses that are on the call, thank you so much for joining. And we've been looking at our screening rates across the region, across NCL, and it's breast screening that is the one that hasn't recovered yet. Patients are required to book in for their appointments. So anything you can do to encourage your patients to respond to their invitation to contact the screening units to get a mammogram date would be really very welcome from us. I was chatting to Kathy Binish some time ago, who's the head of screening for NHS England, and by her calculations, we've got 9 across the whole of London. So that's not just NCL, but across London, we've got at least 900 women short of breast cancer diagnosis than we would have had a couple of years ago if we're just thinking of the effective screening programme. So that's quite significant. Thank you very much to everybody for attending, and hope to see you all again very soon. Catherine has popped in the chat the link to the YouTube channel where you can see this and all our other webinars, and we will, as I said, be diarising a follow-up breast one. Thanks again to everybody. Thank you. Bye-bye.